Okay, let's get started. We've given a few more minutes for people to come in. Let's do a time check. It's 2 minutes past 2 p.m. in Singapore on Friday, 28th May, 2021. On behalf of the SingHealth Duke-NUS Global Health Institute, I'm delighted to welcome all of you. I'm Amina Mahmood. I'm Deputy Director of the Institute. And the talk today is part of our monthly Global Health Seminar series. In these sessions, we draw on our faculty as well as other guest speakers to present topics of global interest. And we really hope to engage with our community in Singapore as well as beyond Singapore and in the region. The topic of our talk today is innovations in big data and real-time monitoring for the COVID-19 response, lessons from Indonesia. Presenting this topic is Dr. Paul Pronyk, who is SDGHR faculty and Deputy Director. And prior to joining us earlier this year, he was the Chief of Child Survival and Development for UNICEF Indonesia. He led UNICEF's support to the government of Indonesia in health, nutrition, and wash sectors, and of course, most recently in their COVID response. He has held faculty appointments with the London School of Hygiene and Tropical Medicine, Columbia University, and the University of Witwatersrand in South Africa. He's a physician and global health specialist with over 20 years of experience in low and middle income countries in both Africa and Asia. His program experience, research interests, and published work focuses on a range of issues, including health system strengthening, evaluation methodologies, and health informatics, which he will focus on today. So we're really looking forward to presenting him today. And before I hand over to Paul, a few housekeeping notes. Please keep yourself on mute. As you know, the webinar is being recorded, and you can post questions in the chat function at any time. We will address them towards the end of the talk. So over to you, Paul, and thank you for being with us.
Thanks, Amina, and good afternoon, everybody. It's really a great pleasure to be here, and I'll be sharing a bit of the work that we did in Indonesia and kind of looking at its relevance to the COVID response here, but kind of more broadly around issues of pandemic preparedness regionally and globally. Next slide. So we live in an exciting time. I mean, the past decade has witnessed nothing short of a renaissance in digital innovations. Blockchain technology is being used to generate highly secure ledgers of transactions across what are now really decentralized networks. And while the most common application at the moment is digital currency, there's a range of health and social applications that are also being tested. Big data, such as our locations, our search queries, our social media content, which previously was only available to advertisers, is now being widely used for social good. Remote sensing and satellite images can now be downloaded freely and used to monitor human or environmental changes through AI and machine learning. And finally, with the widespread use of low-cost smartphones and digital health devices, we're better able to gather real-time information from individuals and facilities. And this is really powerful, especially when you combine it with things like point-of-care diagnostics. You can kind of obtain highly accurate assessments of what's happening in very remote areas. The COVID pandemic has allowed for the convergence of many of these technologies in ways that, in really novel ways, inform public health policies and programs like never before. Next slide. So in this short presentation, I'm going to share how learning on some of these innovations were deployed in Indonesia to support the country's COVID response and discuss some of the wider implications for outbreak preparedness with a focus on low and middle income countries. Next slide. So to start with a bit of context. So I was deeply involved, for my sins, in supporting the Indonesian government's COVID response. And the three most obvious points I'd like to make to start with regarding the onset of the outbreak was that firstly, it arrived early. There was, in 2019 alone, 1.2 million travelers to Bali. Between that short window of transmission happening in China in December and January and travel being shut down in Indonesia, an estimated 300,000 travelers from Wuhan alone came into the country through 5 different ports of entry. Second point is that it was detected late. There was one PCR machine in the country and no COVID reagent. We know from hospital records that cases were likely there in January and February, but the first confirmed case didn't take place until early March. Thirdly, was that there was widespread rapid transmission. Within 1 month, all 34 provinces in the country had confirmed COVID positive cases. And I would argue that this situation is not at all unique to Indonesia and is likely to be common to many other countries in the region. Next slide. So Indonesia is characterized by a host of vulnerabilities that we were really concerned about at the time that would lead to accelerated COVID transmission. The country's only recently transitioned from a low to middle income status. Health spending is comparatively low to Singapore and other well-developed industrialized countries, but kind of comparable to other countries in the region. There's Indonesia kind of in the middle there, as you can see on the left. The country is rapidly urbanizing. It's got a very high population density. About a third of the population in urban areas reside in slum-like conditions. There's extraordinary high rates of poverty, poor sanitation, and limited health sector capacity, particularly around laboratory testing, surveillance, the availability of PPE, and the whole host of concurrent diseases, particularly infectious diseases like dengue and malaria, that make it difficult to unpack what's COVID and what's not. And again, a lot of these vulnerabilities are not unique in any way to Indonesia, but are shared by other countries in the region. Next slide. I'm sure many of you have seen the headlines that have touted Asia's relative success in COVID control, perhaps until the last month or so. But what I'd like to share is this slide, the graph on the right shows, again, with the countries kind of in orders of increasing health spending, levels of testing and case detection per capita. And I have as benchmarks there, the US and Singapore. So as you can see, the gray line is the tests per person and the blue line is the cases per million. So, substantially lower levels of testing taking place in most countries in the region, and obviously in that context, substantially lower numbers of cases. And obviously the testing and case detection largely mirrors wider patterns in health sector spending that we observed from the previous slide. Next slide. So just how bad is the situation? Well, this slide shows the estimated levels of underdetection. The benchmark at the top, the baseline, is fold differences per capita relative to levels of testing and case detection in the US. And we chose the US because it was a similar size to Indonesia, and it did really struggle with its COVID control efforts back in 2020. And what you can see is that Malaysia, Philippines, India had about a 5 to 10-fold lower level of testing and case detection per capita than in the US. Indonesia, a 20-fold difference, and even higher levels of underdetection in Thailand, Cambodia, Laos, and Vietnam, where there was about 40-fold fewer tests done per capita and 2,000-fold fewer cases detected than in the US. So huge disparities and huge discrepancies. So unless COVID is, for some reason, biologically different in Asia and Southeast Asia, it suggests that reports of Asian success, I think, should be interpreted cautiously. Next slide. And it goes without saying that controlling COVID is particularly challenging. I was deeply involved in the Ebola response in Sierra Leone, and Ebola was easier because when people are infected, they get sick. Almost all of them get sick and symptomatic. Conversely, for COVID, around 80% or more cases have few or no symptoms. So once you find 2 sick cases, there's 8 more below the radar, potentially transmitting infection. So few countries have the option of an elimination strategy: Singapore, Taiwan, Australia, New Zealand. And it's no accident that these are islands with well-controlled ports of entry and relatively well-resourced health systems. They're able to adopt precision public health strategies that include screening, early detection, isolation, contact tracing. And this is not a luxury that most countries can afford. And in fact, they have to adopt a COVID suppression. Most countries have to adopt a COVID suppression strategy as opposed to elimination that hinge on effective population-based interventions. But the question then becomes, well, how do we do these interventions effectively? Next slide. So suppression means tolerating low levels of community transmission while implementing public health measures that restrict movement, promote social distance, physical distancing, and promote safe behaviors. And these restrictions are really difficult for policymakers in low and middle income countries for a whole host of reasons that I think many of us are familiar with. But what does physical distancing mean when you live in an urban slum where 8 people co-occupy a single room? What does it mean in terms of access to remote work when your work is kind of leaving the home to do piecework, and your children don't have the option of remote learning? What does it mean in the context of poor infrastructure for hand washing and limited access to health services? So as a policymaker, what tools are available to inform effective targeting of these restrictions so that you can minimize social and economic impact? And in the best scenario, you'd want to do this in a way that anticipates disease transmission as early in the cycle as possible. And this slide shows just some of the limitations in those various steps in the disease transmission cycle. So transmission is kind of happening day 0 to 14, but there really aren't good behavioral monitoring systems available. Cases after infection, people get sick 7 to 21 days after, after being in, at day 7 or 21 in the cycle, but around 7 days after being infected. But case data is often difficult to come by in low and middle income countries because of some of the testing gaps that I reported on earlier. In addition to that, in Indonesia, we found that there was about a 2 to 3 week delay between when a sample was taken and when results were reported. Because often samples would have to get flown in from one island to another to get tested at a lab. And there was a validation process that often took a week to have multiple rounds of testing for a confirmed case. So if you're using case data to decide when to implement your restrictions, you're behind the curve. Hospitalization data, also very, very tricky. In Indonesia, there was no national hospital database. There were limited electronic medical records. There were delays in inputting data. The quality of record keeping was poor. So that was extremely difficult. And then, of course, you have death data. So in each step in this pathway, there's a range of different limitations that really makes it difficult. So in many instances, policymakers are flying blind. Next slide. So how can digital innovations create opportunities for more timely and targeted policy decisions? Next slide. So information from mobile phones. Next slide. There you go. So information from mobile phones is a powerful source of big data, particularly location-based data, which provides information related to population movement. In Indonesia, these data were made available by Google and Facebook through global agreements with our innovations team in New York. And these data were individual data that were anonymized and aggregated down to sort of a 50-meter radius. And from this data, we were able to generate a dashboard on the proportion of people who stay at home. And this is based on comparing their location during the day to their location at night. And you can overlay shape files, GIS files, to examine what's happening in each local area. And you can also look at patterns of population movement between villages, between cities and districts, and between provinces. And we use this information to try and inform policy change in the country around how and when and where to implement social distancing restrictions, and also to monitor associations with COVID transmission. I'll present some of that data in the following slides. So next slide. So this slide looks at the proportion of the population who stay at home on the left axis in blue, and on the right axis, new daily COVID cases, primarily focusing on Jakarta. And we focused on Jakarta because the testing data was most reliable there. And basically what you saw in early March, as cases were increasing, as laboratory capacity increased, our baseline level of people who were able to stay at home went from 40%. So about 40% of people on average in the city kind of don't leave a 50-meter radius of their home during the day. And that increased from 40 to 60%. And we saw quite a predictable reduction in cases that took place. And then as restrictions were eased, we saw cases increase again. Governments then were able to reintroduce restrictions. And there was another case reduction that took place around September, October in the year, only to increase later as restrictions were eased. And what we found from this data set was that there was about a 7-day kind of advance warning between when mobility started to increase and when changes in caseloads were observed. So it was extremely, extremely helpful. And what's also interesting from this slide is that the level of people having to stay at home that was required to see these reductions in cases changed over the course of the year. So as you can see in March and April, you needed to achieve around a 60% reduction to achieve that kind of plateau of cases when your basic reproduction number is 1. And later on in the year, a much lower level of around 50 or so percent was what was required to keep that plateau. So again, very, very, very useful, and it's very likely that that was due to high rates of transmission and herd immunity. Next slide. So are these things this slide just basically shows that there's a strong statistical correlation between people who stay at home and numbers of new cases. I won't spend a lot of time on this, but it's just a kind of a simple regression analysis of cases in Jakarta between March and May of 2020. And this is adjusted for some of the reporting delays that I mentioned earlier. Next slide. So what we're also able to determine is that on average, again, and this changed slightly over the course of the pandemic, but you could also determine the threshold at which are not equaled 1. So where there was sort of stable transmission. And that was really important because it helped policymakers at the local levels to try and more aggressively, let's say, implement their restrictions and to monitor them. Next slide. The other thing that was important in this context was to try and understand wealth gradients. So we were able to use satellite imagery and artificial intelligence with machine learning. And this is stuff that's freely downloadable to look at where people are living in urban slums and what the kind of COVID transmission rates were in those areas relative to slightly better off areas. And what you can see here, not surprisingly, is that folks from the poorest areas and poorest households were much less able to stay at home, had much less compliance with social distancing restrictions than people who came from relatively better off areas. Next slide. And when you look at it geographically, because you can get these maps all the way down to very, very small areas. But what you see is the blue areas show high compliance with being able to stay at home, sort of physical distancing restrictions and so forth. And the red areas show lower compliance. And what this, what this means is that, so this is Jakarta itself is only about sort of 5 million or 6 million, something like that. But Greater Jakarta is around 25 million people. And all of the sort of the poorer areas are in the periphery. And those are folks that are kind of migrating to the center. So even though things in central Jakarta looked good, areas of Greater Jakarta really struggled in terms of being able to adhere to some of these restrictions that were being implemented. Next slide. And the reason this was important is that once we were able to kind of identify areas, there's 2 things that happened. One is that local leaders and local managers were again able to kind of tighten up the restrictions. And secondly, this really woke up the government to the need to implement stronger social protection programs for the poor. So things like village funds and food subsidies and expanding access to cash grants programs and worker protection subsidies. So all of these things were aggressively implemented as a strategy to try and support poor households to enable them to stay at home more effectively, and of course to reduce the negative social and economic consequences of the restrictions, which obviously were quite severe in areas where people really are living at the poverty threshold. Next slide. So to complement this system, another thing that we did to try and address issues around safe behavior was to use mobile health applications to develop a monitoring platform to assess safe behaviors. And in this context, it was mask use, it was keeping a safe distance, and it was hand washing with soap. So we were able to deploy teams of volunteers across the country who did 2 observations a day of 10 people per individual, basically per volunteer. And they went to public places, to schools, to religious facilities, to transport stations, to markets. And they would collect data through a mobile app. Very, very simple, something that really took us, an hour to program. They were able to submit their data into a platform via WhatsApp or an SMS, and it would be automatically aggregated and then fed back to local area managers to give them a sense of how progress was going day to day. Next slide. So this just shows you a real-time dashboard that was available. Again, that could visualize progress all the way down to the village level, providing, again, automated feedback to district officials on levels of mask use, hand washing, and physical and safe distancing, and sort of charted trajectory over time, and had you it was really important because it helped local area managers kind of see how they were doing relative to, say, district or provincial averages, or relative to neighboring districts. And it really kind of incentivized them to take a stronger stance in some of the areas where there were still persistent challenges. Next slide. So in summary, prior to the introduction of these innovations, policymakers were basing decisions on the implementation and introduction of these restrictions based often on low quality testing data, on hospitalizations, and on deaths. And the use of big data and real-time monitoring with AI support allowed for closer monitoring of key behaviors earlier in the disease life cycle. Again, it was highly predictive of transmission with sort of a 7-day advance warning. It was used in ways that were complementary to the existing clinical data, with all of the gaps that I mentioned earlier. And it allowed for more localized intensification of COVID control measures. And again, that feedback to local managers was important, particularly given Indonesia's highly decentralized governance systems. It also allowed for the identification of vulnerable groups and vulnerable areas, and more effective targeting of social safety net programs. Next slide. So our experience from Indonesia demonstrated one very modest application of data innovations that assisted policymakers to better respond to COVID-19. But moving forward, I think what's really critical is to apply this learning to wider approaches that help us to better anticipate disease transmission. And this is important because on average, a new disease in humans has emerged each year since World War II, and 60% of these have come from animals. This slide demonstrates the One Health framework, which, for those that aren't familiar with it, is a global agenda to understand interactions at the human, animal, and environment interface. Data innovations that build upon the sorts of technologies that I shared today can be used to really help us better understand and unpack dynamics at each point in this One Health framework. I've shared information on how AI and big data can provide insights into population movements, but there's also a range of other applications. For example, Facebook has recently made available through its Data for Good program, a range of mechanisms that allow for social listening and targeted engagement through social media outreach to try and understand community perceptions, improve awareness, and build trust. It was something that we were using widely to counter issues of vaccine hesitancy related to haram halal issues in Indonesia. Furthermore, remote sensing can be deployed to help us understand how shifts in climate and biodiversity influence vector ecologies in human settlements. One great example of this, of course, is in the malaria field, looking at how global warming influences mosquito breeding sites and subsequently shapes malaria transmission dynamics. As I mentioned, mobile platforms can provide real-time assessments of what is taking place at the human-animal interface. It's very easy to see applications to sentinel surveillance and early warning systems. And again, I think it can be particularly powerful when combined with point-of-care diagnostics to give us a sense, a biological sense of really what's happening on the ground in remote areas that are far away from clinics and hospitals and where there is no laboratory. And finally, innovations in human, animal, and viral genomics can help us anticipate how pathogens move between species, which are harmless and which require further observation. And the aim of really strengthening these systems would be to design and employ and deploy systems regionally and globally that help us understand these complex relationships so that we might better predict, prepare, and respond to the next pandemic. Just as a quick plug, my final slide. For those that aren't aware, Singapore will be hosting the World One Health Congress from November 7th to the 11th in 2022. This is really the world's premier congress to try and understand some of the issues that I've alluded to today in the discussion, and really profile important works in One Health science, in real-time monitoring, integrated dashboards, in clinical innovations, in policy and the environment, and that whole interface, as well as key issues such as antimicrobial resistance. So it'll be a great chance to really get together to talk about these things. It'll be hosted by the SingHealth Duke-NUS Global Health Institute. On the one hand, we hope it's going to be an opportunity for countries around the region to really reflect upon the COVID response, sort of a post-mortem that brings together scientists, policymakers, and practitioners, but also thinking in a much more forward-looking way to how to future-proof and what can we learn from this to help us prepare for similar issues that are inevitably going to take place in the future. So this has been much shorter than I thought, which I suppose is good. But it's gives us a chance to engage around questions and sort of look forward to your engagement. So thanks very much for the chance to be with us today, and really look forward to any questions you might have. Thanks.
Thanks, Paul. That was great information to digest. So while we wait for maybe some people to gather their thoughts and ask any questions via the chat function, we did get one question when we asked for registration. So let's go ahead and address that. So this was a question asked: what is the most difficult challenge in data access and data gathering process? What are the legal and privacy issues?
Great question. Yeah, it's something that 5 years ago, we were doing work on big data in particular, and there was just very, very little available in the public health context. And it's really just been in the last couple of years that that Google and Facebook and others, Apple, have made their data available in a way that's accessible for public good. There are huge agreements around how that data will be used. So that kind of happened. We were very fortunate at UNICEF that there's a lot of high-level engagement around that. But basically, the data does come in a way that is anonymized and aggregated. So it's not necessarily individual data. It kind of gives you a sense of what's happening in an area. But I think the implications for privacy are quite substantial, and it's something that we had to kind of face quite seriously with UNICEF because of issues of public trust. The Facebook data that I mentioned is another issue where you can Facebook is actually making available people's perceptions to try and look at, what are they searching, what are they talking about in their chats. Again, not individuals, but types of people. So you can look at what are nurses saying. You can look at what are parents with children saying, what concerns are being raised around immunization. And what they'll do is they'll allow you to make those observations, and then you do what's called brand lift studies, which effectively are ways of trying to influence discussions online through kind of positive social messaging to try and influence, again, community awareness, to build trust and so forth. This is information that's been available to advertisers for a very long time. It's the backbone of how these companies make money. But it's only recently been available to, for public health and public good. So the privacy issues are quite serious, obviously. I think privacy is certainly the new frontier for a lot of the digital space. But other than kind of anonymizing and aggregating data and doing things that, where people, and often there are consents. So, but I think you've all seen the kind of Facebook consents where they have you opt in rather than opt out, and where some of the fine print can be a little bit overwhelming for the average user. But again, it's an area that we need to get more and more involved in. So it's a great question, and I don't think there's any easy answers. But what is good to see is that we are starting to have this debate, and we're starting to use this data for things other than selling the next brand of Pepsi Cola to people.
Absolutely. And like many good things, there's always a downside. So I think the whole issue has to be managed very carefully, but looking at both sides is essential. How can we use it effectively, but how can we protect people from that? And we have another question, which is how was it like working with the Indonesian government to develop and embrace the data analysis and recommendations? Were there any challenges?
Yeah. Well, a lot of the challenges are, it was reasonably easy to get them to embrace a lot of the innovations that I talked about here, simply because the existing systems were so poor. Most clinics have no individual patient records. Hospitals don't have electronic patient records as well. Laboratory reporting is poor quality. So I think they recognize all of these limitations. And obviously, it's a long process. It's a 10-year process to build a proper electronic medical record system, for example. So this was a way that, and this was not, in terms of the team required to do this, this was not 50 people, right? This was like 3 or 4 of us that were doing this in cooperation with folks at UNICEF Innovations at headquarters. So it wasn't that difficult to do in many respects, and it helped us, again, kind of leapfrog a lot of the traditional bottlenecks, because again, quite frankly, we were working directly with the president's office, and they were making decisions about what was considered high risk and low risk based on deaths and hospitalizations. And it was, that's too little too late. So I think they were relieved to be able to have access to this information. Again, it wasn't used in place of clinical data, but in a way that was kind of complementary to it. So it was kind of an important adjunct. And I think there's a broader realization of the government of the need to engage more proactively in these issues, particularly around the use of mobile health, which has been really helpful, as well as the use of AI and satellite imagery, particularly around the poverty mapping work, because in such a big, complex country, to do detailed household surveys to track this is the kind of thing that governments can only afford to do once every 5 years, and often some of these really difficult urban slum areas that are changing rapidly are undersampled. So being able to kind of have these quick bird images to kind of take pictures of what's happening and then kind of correlate them later to socioeconomic surveys is just a really powerful tool. So it's an area that they're very, very keen to move into, and I think it's been, this whole experience around COVID, I think, has really helped to push the envelope in terms of getting them more engaged in the space of digital innovations.
Great, thanks. So another question that's come in is, what is your view on many emerging mobile applications that track and trace, monitor behaviors, etc.? It seems challenging to analyze different sources of data. Do you have advice for private sector who seeks to also develop mobile applications for health purposes so the data gathered can contribute as well? So basically, how do you bring all these different elements together to make a kind of, I guess, one concerted effort rather than many spread out disparate efforts?
Yeah, one ring to rule them all. After working in Africa for 10 years, I mean, there was a lot of countries actually put a complete hold on new digital innovations, because there's so many pilots kind of coming up, all using proprietary technology and with databases, data systems that were not interoperable, and it created a huge amount of challenges in terms of making sense of things. So there is an emerging movement to try to harmonize these issues and to ensure there's open source, open standards. Open source means the programming, it's not proprietary. Open standards means that it adheres to certain types of programming language that allows for database interoperability. So I think that's an important first step in terms of trying to create some sanity in the digital health space. And I think once you have that, and obviously ensuring that there's government ownership is also really, really key. So a lot of this work kind of starts as kind of pilot work, but eventually it's going to be quite important to ensure that the government is really in the driver's seat, because things can become anarchic very, very quickly. And also the technology is really evolving. So I think what's important to understand is how different types of applications can be seamlessly integrated within national health information system frameworks. And depending on the maturity of the HIS systems, there'll be opportunities for different types of innovation. So for example, in village health posts where there is currently no data collected, right? You're starting fresh. You can really use kind of cool real-time monitoring tools that can, again, leapfrog a lot of the traditional bottlenecks. In areas that are more mature, where you have clinics with computers and stuff, having a standardized electronic medical record system would be the way to go. So trying to understand how things would interact with that current health information ecosystem is really critical as well. So it's a very complex, rapidly evolving space. And it's been really, it's a great place to explore, a fun opportunity. And I think for me, in the One Health space, trying to bring together some of these much larger data sets to try and help us provide insights around some of the, this complexity, I think will be really important in terms of really trying to, again, predict, prepare, and respond to outbreaks moving forward.
Yeah, absolutely. So there are a couple of questions which are a little bit more focused on Indonesia. So let's go through those. One is, has Indonesia's decentralization helped or harmed the government response?
Well, it's not really it's not a yes or no answer to that. I think Indonesia is a very complex country, right? It's 270 million people, 7,000 inhabited islands spread over a geography that's wider than North America, right? With vastly different languages and cultures. And I think, for the government, just kind of decentralization was a way to hold the country together. You have, areas with Sharia law in Aceh all the way through to indigenous tribes living in the forest in Papua, all of them fiercely independent. So having strong local control is really important for kind of keeping the country together. Of course, it doesn't make governance easy, right? Because often you're relegating control down to local areas that have often kind of limited capacity. So there's a huge learning curve, and there's a huge investment being made by the government to really improve district capacity. In particular, the Ministry of National Planning and Development has been a kind of a huge proponent of that, and really trying to develop health leadership and health management systems along that supports the Ministry of Health and Home Affairs and so forth. So it's a double-edged sword, and I think Indonesia still is kind of in that kind of learning curve. I think a lot of the areas in the central part of the country that are relatively well-resourced, particularly on Java, some parts of Sumatra, do extremely well on their own. And these are huge provinces, whereas some of the areas in Eastern Indonesia, I think, still struggle. And it's going to take another 10 years or so until we really have kind of strong and effective governance. So I'm not sure, that's not an easy answer, not an easy question to answer.
Yeah. Well, there's another question. Again, looking across Indonesia, poverty is a big issue. So how do you think this dashboard can help people, help those people who are going out by risk, they'll be risking COVID, but staying home means risk of starvation. So, how can these tools play a part in, I guess, mitigating that balance factor between those options?
Yeah, great question. So what's important about, so there's a lot of dashboards proliferating, and a lot of them are of variable utility. And what I've learned is, what's important about them, if they're really going to be helpful, is to really limit the data going in, that it's really simple and actionable. And no one's going to look at the internet, right? It's unusual. So you need to kind of build in automated feedback loops where when someone's entering information into the system, they get a feedback message saying, thanks for submitting. You have 40% of people correctly using masks this week relative to 30% last week. So there's that kind of immediate feedback that's happening. And that was really important, again, particularly in a decentralized context where, again, people aren't on computers, but they all have smartphones. So being able to send that kind of feedback to them and saying, hey, here's how you're doing, and here's how you're doing relative to the average, and here's how you're doing relative to your neighboring district, is really empowering for local managers in terms of being able to kind of balance some of the issues that you mentioned in the question around, issues of trying to keep the economy going and mitigate the negative social and economic impacts with the kind of public health imperatives around COVID. And it's not an easy balance. And I showed you the data from Jakarta around folks staying at home, going from sort of 40% to 60% and pittering around there. But in a lot of other areas of Indonesia, particularly in poor areas of the East, the successful implementation of these restrictions was limited, to say the least. Very marginal adherence to national recommendations. And then the president recognized that. I mean, it was a trade-off that he didn't really have much choice because of these, farmers have got to go to the fields, people living in urban slums have got to make a living, even with the expanded social protection programs from COVID-19, it's still just a drop in the ocean in terms of being able to address some of the, profound issues of poverty that people face. So yeah, so that's it's one of the reasons why I think in the earlier slides I was talking about kind of how successful has Asia really been, because I can tell you that the underreporting in Indonesia is, it's probably the real number of cases is certainly 20-fold more than is currently being reported, I would guess. And it certainly feels right being on the ground for 5 years there and really understanding some of the health system's capacity gaps. And again, I'm sure the situation is not that dissimilar in Laos and Cambodia and Vietnam. But like I said, it needs to be interpreted cautiously. Yeah.
Yeah. Okay. Okay. Still with Indonesia, but a slightly different tact. Does Indonesia have any capabilities in One Health, especially monitoring pathogens moving between the human and animal populations, or do they only track once it's in the human population?
Even tracking in the human population is difficult. I mean, it's surveillance systems are not ideal. They're, it's even something as reasonably simple as measles surveillance. It's just not happening. And COVID has made it in many respects quite a lot worse, right? With people reluctant to go out and do their jobs, and districts. Yeah, so I mean, it was a previous talk that I think I gave for this series talking about, massive reductions in immunization rates, and we're going to have certainly a massive bump in vaccine preventable diseases in a lot of countries. I think a lot of that's being undetected right now. So I think even human surveillance is not happening optimally. And we've gone through measles outbreaks, diphtheria outbreaks, polio outbreaks in the past 5 years, Zika virus outbreaks. At one point, the Indonesian government, there was some Zika outbreaks in Singapore, and I think they had banned flights from Singapore to Indonesia, and then they were doing mosquito spraying around the airport in Jakarta. And we did some further research based on blood samples that were collected for dengue that showed, extremely high prevalence of Zika in Indonesia. It's like you've been there forever. It's just been undetected because of issues of cross-reactivity with dengue and so forth. So yeah, systems for human animal surveillance are still evolving and need a lot of support for sure.
So maybe I'll pick up on that point. Obviously it's for LTGHI, his health system strengthening is a key topic, and we're really concerned about what we can do in that area. So even beyond, of course, there's the data analytics piece and then, getting the information, getting the surveillance piece is in there. But just because you know Indonesia so well, I'd ask you, given all the limitations that have been even further exposed through COVID, what's the path forward for them? How do they, really get onto that path of health system strengthening, getting to universal health coverage, which is, I know, a goal of theirs, but which they, there's a gap in achieving it. So what are your kind of, thoughts about to be effectively at least starting down this path?
Mm-hmm. That's a great question. So universal health coverage, the whole concept of universal health coverage is around trying to make improve coverage of interventions, improve quality of interventions, and make them affordable to all. And in all respects, when you look at what's happening in Indonesia over the past 10 years with the economic increase in the country, there's been almost a parallel reduction in levels of preventable deaths, particularly under 5 mortality and maternal deaths. So they've done really quite an extraordinary job improving coverage. I think that's kind of covered. Their big gap right now is improving quality. And in terms of the healthcare financing, they're still spending a relatively small amount of their GDP on health. And they have a private system that desperately needs to be regulated. But the one thing that they've done that's fantastic is they, when I first arrived in Indonesia, they had fragmentation of the health insurance environment where every kind of district and province had its own kind of health insurance scheme. Over the course of the past sort of 5 or 6 years alone, they have enrolled almost the entire country, like 80% of the population, into a single national health insurance plan called JKN. And that, so everybody under a single umbrella really gives them an extraordinary lever through which to control costs and to try and address some of the health-related inequities. So I think this is something that they recognize, and that really for them is kind of the first step. And so financing, because half the system is kind of private, the other half is sort of public. Lots of folks are using the private system, and the costs are through the roof. Something like I don't know, 60% of health spending was on cesarean sections and dialysis or something. So it's really skewed. But because the healthcare financing folks are so strong and everybody's now enrolled in a universal coverage package, it gives them a lot more opportunity to control costs, to have a set of standards, and to work towards improving quality, which really is kind of the next frontier for them. So access and coverage is kind of sorted. It's kind of just quality, and financing is now reasonably okay, although they need to increase spending. So the issue now really is around improving quality, making sure that mothers don't die. Mothers who used to die, there's a thing that we say where mothers used to die in the community, now they die in the hospital because the quality of maternal care was still really struggling. And they recognize that, and there's huge initiatives to try and make sure quality of care is substantial. So I think they've done great in the past decade, given some of the significant constraints that they faced.
That's good to hear, positive kind of outlook for Indonesia as a whole. Let's go back to some more data explicit questions. So this has come in. I think one of the biggest issues regarding big data is that lots of times people will not even notice that their behavior communications are collected without their explicit consent. Do you have any thoughts on how to improve the whole process of collecting these new types of data?
This comes down to the first question around data privacy, I think.
Yeah.
I don't know about you, but it's always really pissed me off to have that same advertisement following me around on every single website, So again, advertisers have been doing this forever and nobody blinks an eye. And this is how the biggest tech companies in the world make money. And it's a problem. It's a huge problem. And there needs to be a much stronger attention to data privacy related issues. As I mentioned, Facebook has a disclaimer that you kind of have to opt in for, that they can use your data for these purposes. I think WhatsApp now has it as well, and Instagram. And so companies are really taking advantage of this stuff. And it's, on the one hand, it's fantastic that they're making this data available for public good purposes instead of just to sell you products. But I think the whole issue of privacy and individuals being able to sanction which of their information is used and which cannot be used is incredibly important to get our heads around. And I think with multinational companies, again, working between legal systems, it also creates serious loopholes for our ability to kind of regulate these things. So it's an emerging domain. It needs a huge amount of support. It needs a lot of further thinking and regulation. And I think it's really good that, at least for the first time, public health practitioners are at the table to really understand some of these systems and be able to engage in the discussion in a constructive way.
Yeah, lots more work to be done. Okay. Another question, is there any dynamic big data on healthcare workforce in each population, I guess, Indonesian population, to guide government's policies on future workforce training and funding?
Yeah. There are, almost every country's got a health workforce database. And it's not a hard one to collect because you have to pay health worker salaries, right? So it's not like you're collecting individual patient data at a remote village health post somewhere where there's no internet connection, right? You're having to kind of pay doctors and nurses and physical therapists and speech therapists and what have you So when they're on the payrolls, you have a reasonably updated database. I know Indonesia and most countries with WHO support in particular, do have these inventories available. And of course, they show, massive inequalities in the distribution of healthcare providers between urban and rural areas, between well-developed and poorly developed parts of the country. And this is used for planning, for incentivizing health workers to work in rural areas, for having differential salary allowances. So there's all kinds of programs that are underway to try and address some of these kind of disparities. But obviously, having good data is key. And again, most of it, my impression that it does exist. And is being used, but it's just one piece of a much more complex puzzle, I think.
And we've got a great comment from Emily Hertzman and from our audience. She's given you a contact. So if you're not looking at your chat, if you open up your chat, you'll see a link. She's provided a link saying this is an interesting resource to understanding the economics of a hidden of big data collection. So thanks, Emily, for that. Then we had another question. If you could share a few enhanced implementations based on big data collected. I'm not 100% sure what they mean by the question. Maybe, a few examples of, projects that have used big data. I hope I've interpreted that correctly.
So, the ones that we used, again, it's pretty new in public health, right? Really, really new. And again, as I was saying earlier, even a few years ago, I was frustrated at the fact that this stuff wasn't more widely available and that the big data sets that public health practitioners had access to were pretty pithy. So I think this is still a new and emerging field. Again, the big applications that that we've used it for are really around understanding this business around kind of stay at home. If you do leave home, where do you go? Are you going to the markets? Are you going to church? Are you going to take your child to school? So you can actually look at that because each of these markets and schools and sort of have GPS locations so you can see people moving. You can also look at movement between areas, which is really important to understand disease transmission dynamics. It was used early in COVID to understand, models of you could. Maybe another good example would be to say, because these things are so predictive, right? Movement and transmission. When you looked at what happened in the UK, and when you tried to understand issues around, say, variants of COVID that were more transmissible, your insights come from this data, right? So you're seeing all of a sudden levels of mobility and movement are staying constant. So transmission has a predictable relationship to transmission. So all of a sudden transmission is going through the roof. Something's happening. All right. So I think a lot of the Oxford University has a similar kind of system that they've used to what I presented today. I think was quite important in terms of trying to understand some of these dynamics around more highly transmissible variants of COVID. So I think that was an important insight. I think other aspects of big data were what I mentioned earlier around the Facebook data, where again you're able to have anonymized metrics of people's perceptions in the community, and then use that information to try and shape perceptions through what's called low quality, high content postings of, for example, positive messages to try and change and shift perceptions of key groups that say don't want to get vaccinated. That's another kind of very, very up and coming use of it. So we did that in Indonesia as well, in some of the deep Sharia law areas of Aceh, to try and address some issues around vaccine hesitancy. And it was incredibly effective. They said it worked. The stuff that we were doing worked better than any sort of product placement that they had done previously. It was with a marketing firm that we were working. They were through Facebook's Data for Good team. So I think those to me are the kind of the key examples. But this is as I say, it's a booming area, and as I was saying, it's a data innovation renaissance in many respects. And it's really up to us now that we are at the table to start asking some interesting questions of the data and try and use it in ways that really can try and help support delivering essential services where they're needed most.
Great, thanks. Those are nice examples. Okay, another question. Can the new centralized health insurance scheme be built into a national health information system?
They're trying. Yeah. The problem is with data systems in general is you got to get it right from the start. And because of decentralization, every district got its own data system, proprietary, locally run, funded through district budgets and district contracts, and it doesn't come together. So what they're currently trying to do is take all of these 500 or so data systems and try to retrofit them, meaning that they, which is an incredibly difficult thing to do. Don't ill-advised to try and, because unless you get your definitions and your indicators and your metadata, unless there's standards for it, trying to fit things in after the fact is extremely difficult. So it's a 10-year process, and there still, to me, is not really a strong district health information system. In most countries in Africa that I've worked in, they have better district information systems than Indonesia does, which is primarily a result, I think, of decentralization and local governance and the lack of unification, the lack of uniform standards around data collection, use, entry, analysis, and so forth. So it's a huge challenge.
Yeah, and being the decentralized, there are advantages to it, which you pointed out to earlier, but then these are the downsides of that decentralized approach. Right? So everything always has a positive and a negative point. But with that, I think we're just kind of at our time. We also don't seem to have any new questions. So I think I'll say thanks a lot for the presentation. Thank you for the audience. We had great questions. Really very interesting kind of discussion. We could go on talking about this and talking about both sides of it for a long time, but hope to continue the discussion with all of you. And thank you for being here. Thank you for presenting. Thank you, team, for putting it together as always. And see you next month in our Global Health Seminar Series. You'll be getting an email soon about what the topic will be.
Thanks, guys.